through like what I got all twisted up about this last night. Yeah, I can see you.
Okay. So,
I don't see your slides though.
no, I haven't tried to share the slides yet. So,
logged in, I forgot to two different. Oh, and I can type it to you. Really? Huh.
okay. Now, can you hear my?
Hold on a sec. Let me get
Okay.
out of. I didn't think I was in two sessions. I am in two sessions. All right, go ahead.
Okay. So this is saying it's recording. I'm going to try and share my
I
slides.
think I have video. I must be able to do audio because you can hear me, can't you?
Well, I don't know if I'm hearing you from my phone. I don't think I can hear you from the computer.
I could before here because I could mute. I could hear myself through the computer before. You know what? I'm going to go back. Anyway, to the phone. Anyway, that doesn't really matter. I'll figure that out later. I'm more curious about you. So do you understand how to click and share your stuff?
I believe so. We're going to try it and see how that works.
Because I got all worried last night, clearly.
Yeah. My biggest problem right now is getting my...
Jackie is saying, I'm on, but can you hear? So we can't.
No.
I don't think I can see. No, but I wonder if I went on my other one.
It won't let me.
It won't let you do it?
No, it won't. My cursor for my... I can't get the cursor on that screen.
Why? Because you have two screens?
Yeah, I actually have 3 right now because I'm in my office and using the webcam, which is on my laptop. And it's not. I may have to shut down the other screens.
Sorry, I'm like, if you hear something in the background, it's because I'm supposed to be at this other meeting and I'm listening, but I'm not presenting. Oh, okay, so I can see your other screen.
Okay.
And I think if you put it in the reading view, remember I was trying to show it's like a book on the bottom? Yeah, I see you clicking on that. And then I think you can, you're side by side. What I see is side by side.
Right. Okay, is that better? Because that's bigger.
Really, it doesn't make it any. It makes it bigger on the thing, but I wonder if you can. I think you can maximize because right now you're side by side. The slides are as big as you are.
I think you have to click twice on your video on your screen too.
Oh, I can do that. Yeah, I did. I clicked twice and I maximized. Yep, that's perfect. Yes, it did exactly that.
Okay.
That's great. So clicking, that's perfect. That is exactly what I want it to look like. The issue is I can't hear you through my computer. I wonder why. I can see you. I can hear you on, I can see you, but I can't hear you. I'm thinking it's on my end.
Okay. Do you want to?
Are you have your mic on, right?
It is on. Yeah.
I think it's not you. I think it's me because I could hear you through my other computer.
Okay.
Which doesn't make any sense. That one computer. Oh, you know why? I'm so stupid. You know why? Do you want to laugh? Because I have my earbuds.
Okay. I've done that before.
I was like, I'm so stupid. I'm like, why? Okay, let me. See, I know it's me, so I can now at least.
Okay, is that better?
Yeah, that's totally.
Okay, perfect.
I'm just laughing
Testing volume. Amy, can you hear me now?
Lauren, can you hear me now?
Yes, I can, Jackie.
I can't hear anything now. Maybe.
I don't see your video, Jack. I heard you.
I went on to Microsoft Edge, and somehow that allowed me to do it. I had to jump off Chrome.
Can you all hear me?
Yes.
Okay, I hear you. Does can you all hear each other?
I believe so. I heard Jackie before.
Okay. Is there audio with your presentation?
No, it's just me talking. There's nothing separate in terms of a video or anything pre-recorded.
Oh, okay. Well, Jerry had kind of sent the SOS that you guys had some audio issues, so I'm glad to know that you don't. And
Well,
that
I
everything
think
is
that
better.
Jackie originally had a hard time getting her audio set up, and Jerry did as well. But
Okay.
I don't know if Jerry's still trying to do that.
Oh, she says the audience had audio issues. So I don't know that the audience can speak back and forth. But they should be able to hear you. So I would encourage them to use the chat.
Okay, there was a question earlier about audio, but I was speaking with Jerry on my cell phone and not via the computer, and I had myself on mute. So I think that was the issue earlier. Hopefully that was all it was.
Okay. All righty. Well, I'm going to mute myself. I have some other things in the background, including an interview. So I will mute myself, and if you need anything, just holler.
Thanks, Michaela. I appreciate it.
Very welcome.
Can you all hear me now?
Yes.
All right, I can hear you, and you can hear me, and I'm on my phone. I could not get it to work on my computer. I couldn't hear anything.
That's crazy. Well, I'm glad we can hear you now.
Yeah, so I'm sorry, I'm mobile, but I mean, I'm here. All right. Well, I'll go mute, and hopefully this will work. I might try to mess with it just up until then, but at least I got this backup. All right, it looks like it's officially 1:30. This is Jackie Simmons. Maybe we'll give people another minute just to get back from lunch and then get started. Feels like I've had a few technical issues, so it feels like it might be good just to make sure everyone's getting on. I hope, well, I don't think me saying I hope everyone has sound is going to help with folks that don't have sound, but I had trouble having sound earlier, so maybe I can type that in and just make sure. I have tried Chrome, and I think it's called Edge is the Microsoft version of the browser, and now I'm on my phone with voice, so I hope that is coming across clear. I think we're all going to be IT experts after all this COVID stuff. Great. So it looks like people can hear. That's great. Great. All right. Well, we're a minute after, so let's get going. I get the pleasure of introducing my colleague, Lauren Howard, who's going to be speaking on advancing health equity, including disability in the conversation. I am Jackie Simmons, and I work for the North Carolina Child Care Health and Safety Resource Center. And I've been with the Resource Center about 5 years, having come from the Office on Disability and Health. I did not get the privilege of overlapping with Lauren, but I do, when times are more normal than they are now, I get the pleasure of sitting not far from her at the Division of Public Health. And I know what wonderful work that they do in her office. I will say that on a personal note, I learned more working with the Office on Disability and Health in my short time with them than I think I did, well, not my whole career, but it was just a really eye-opening and wonderful experience and a perspective that I will always hold dear. Lauren is the director of the Office on Disability and Health. And as I mentioned, it is in the Division of Public Health in the Children and Youth branch. She has a master's degree in rehabilitation, psychology, and counseling, and more than 25 years of personal and professional experience working to promote the health of people with disabilities and ensuring the inclusion of people with disabilities in public health activities. So I will let her get started. Thank you all. I'm happy to keep an eye on the chat too. If anyone puts questions in the chat, I will let you know, Lauren, if you get any good questions coming in throughout. And thank you.
That sounds great, Jackie. Thank you so much for that introduction. And before we get started, I will just do one more quick sound check. Everybody good on sound? Thumbs up if we're good, Jackie. So
yeah, it looks like people are doing good with sound. Getting some positive feedback.
So we will get started. Before I jump into presentation this afternoon, thank you all again for your time being here today. I want to give you a little bit of background about the Office on Disability and Health. As Jackie alluded to a little bit, the goal of our office is to promote the health and well-being of people with disabilities in North Carolina by working to improve access and inclusion in public health programs, addressing health disparities, and promoting health equity. And we do this through training and technical assistance and working with state and community partners to increase awareness of the health-related needs of people with disabilities, and to improve access and influence policy in public health arenas to ensure that individuals with disabilities living in North Carolina are healthy and included. And so with that, let's jump in and hope that I can get this to advance. Okay, great. So what we want to cover this afternoon in our brief time together is I want to start by giving you an overview of disability in the context of health equity, including the role of race, ethnicity, and social determinants of health. We're going to review some health disparities and barriers to health equity for people with disabilities, and then look at some practical steps to address barriers to health equity for people with disabilities and promote inclusion. So it's a big, lots of big topics. We're going to do some surface level look at some of this, and then hopefully provide you some resources at the end for a little bit deeper dive into some of these topics. But before we dive into the first of these objectives, what I want to do is provide a context of how we're going to discuss disability. This may challenge your view of disability a little bit, which is good. I think with any topic like this, that we're trying to really think about your personal bias and stereotypes, and if that needs some adjustment along the way. I want you to think about disability very broadly as a part of the human experience, recognizing that all of us at some point in our lives will very likely experience disability, maybe temporary or permanent, but we will likely experience it. I want you to think about disability in a social and environmental context, kind of not ignoring a diagnosis, but really focusing in on that social environmental context versus the actual disability diagnosis. And then I want you to think about the intersectionality of disability, how race, ethnicity, culture, gender, all intersects with disability or perceived disability. And this slide shows just some of the basic definitions or qualifications for a disability. And I picked those that represent that broader view of disability in a social context. So, as many of you know, the Americans with Disabilities Act was signed now 30 years ago. It was a landmark civil rights law for individuals with disabilities. And their definition of disability looks at a physical or mental impairment that substantially limits one or more major life activities, focusing then on the social context. The Centers for Disease Control defines disability as any condition of the body or mind that makes it more difficult for a person to do certain activities and interact with the world around them. And likewise, the World Health Organization calls disability an umbrella term for impairments, activity limitations, and participation restrictions in the interaction between individuals with a health condition and personal and environmental factors. So that's the perspective that we're talking about related to disability. And so let's look at how many people we're really talking about in North Carolina. So if we look at the graph on your right-hand side related to adults with disabilities, we'll start with adults. According to the 2018 BRFSS, 28.8% of those over the age of 18 in North Carolina identified as having a disability based on 6 screener questions that the BRFSS uses to define disability, and it's by functional status. It's looking at hearing and seeing and mobility and cognition and self-care and ability to live independently in the community. But we know that the BRFSS doesn't really give the whole picture because we're just looking at adults. So we wanted to look at the National Survey of Children's Health, which identifies those children with special health care needs in North Carolina. And we see that we're still talking about 21.2% of children in North Carolina are identified as having a special health care need. Now, a special health care need, the definition is going to be a little bit different than the definition that the BRFS uses. They're looking at using the maternal and child health definition of special health care need as being children who have or are at risk of a chronic physical, developmental, behavioral, or emotional condition and needs health-related services beyond those generally required. So just so you know the context of how they're measuring special healthcare needs. So in this, we see that we're talking about a pretty significant part of the population of North Carolina, and so that's why this really needs to be part of the conversation, because we're not talking about a small percentage of the population. And just as we're talking about disability broadly, some other things that are important to keep in mind is that many disabilities are not visible. Many of them are invisible. You're not going to be able to tell by looking at somebody that they have a disability. Disabilities can be temporary, they can be episodic, or they can be persistent. And people with same disability may be impacted in very different ways. You can have a similar diagnosis and very different experiences. People may not identify as having a disability. You may look at somebody and say, oh yeah, they have a disability, but they may not choose to identify as having a disability. And so I think most importantly, this last bullet, recognizing that disability includes every age and race, ethnicity, culture, gender, religion, education level, and socioeconomic status. Disability is not a homogeneous group. And so let's dive into that just a little bit. I wanted to show you this table that shows the race and ethnicity breakup according to the 2018 BRFSS data. So remember that we're looking at the prevalence of disability as 28.8%. And so when we look at this chart, we see really pretty similar rates of disability across different ethnic and racial groups. And so what that shows us is that all racial and ethnic groups experience disability. We don't have the statistically significant differences between racial and ethnic groups, but it shows us that prevalence across groups. And so this is important because those who identify as having a disability obviously are not from the same group. Again, we're not a heterogeneous group, not a homogeneous group, excuse me. We're a very heterogeneous group of people. And just like individuals with disabilities may not have the same gender or age or education level, socioeconomic status, they're also not from the same race. And so I think that this is sometimes portrayed incorrectly in media, where you see a lot of pictures of individuals with disabilities who are white. And I think that goes across many different issues in media, but I think especially within disability, that's, at least for me, that's primarily what I see. And I think that that's an incorrect representation. And so we'll look at the same thing related to children and youth. It's very similar when we look at the data from the National Survey of Children's Health and see that, again, children with special health care needs represent many different racial and ethnic groups. And so what I wanted to show you in this slide is just how over many years, what many people have considered the disability rights movement, many changes in laws and stereotypes and structures in the society that we live in this country. Really, there has been a shift. And there continues to be this shift of rethinking disability. And so as we consider disability through the lens of health equity, we really have to evaluate and challenge our own thinking of disability and the experience of people with disabilities. And so much of our thinking comes from historical context, family experience, language, stereotypes, media portrayals. But I want to highlight kind of how this shift is happening where the goal needs to be as we think about disability and as we consider disability in the context of health equities. And so as you see on the left side of your screen, we have more of what is considered more the medical model of disability. And you have the shift to the right side of the screen where it's more of a social model of disability. And so the medical model focuses more on the individual, and then the social model focuses more on that societal context that we've been talking about. And so before I go into the specifics of these, let me give you a personal example. You can't tell, obviously, because in this virtual environment, you can only see my head. But I have a disability, and I have been a wheelchair user for over 30 years. And so I have, in terms of the disability itself, I have an impairment, which is paralysis, but I am disabled by my environment. So per se, if I use a wheelchair, I'm in my home environment, which we have eliminated all of the structural and physical barriers. I have ramps, I have doorways that are wide enough, and I have other things in my home that make it easier for me to get around. My disability is not noticeable. It's not a big deal. I get around my house just like my other family members who do not have disabilities. But if I go into a building that has stairs, or it doesn't have an elevator, or has other structural barriers, then my disability is much more heightened. I'm very aware of my disability in that environment because of those barriers that exist. And so just pointing out how that social and environmental context really makes a difference for me personally. It's pretty significant. So if we look at this shift on the slide, we have hopefully this shift in thinking from disability being very negative, something that's horrible that happens to somebody that should be pitied, to that shift to disability just being a natural part of life, that many experience disability. And then the shift from individuals being an individual problem, that my paralysis is my problem, to something that society needs to address, that those barriers need to be addressed by those outside of myself, and that my disability needs to be fixed or cured. I'm fine. I don't need to be cured of my disability, but I need to be accommodated. My disability, the barriers need to be addressed, but not necessarily the impairment itself. The shift in focus from limitations to environmental changes. We've already talked about understanding disability not as a homogeneous group of people, but a very diverse group of people. And I think really importantly in this public health context, we need to recognize that people with disabilities are not inherently unhealthy. Just because they have a disability does not mean that that individual is unhealthy, that we have to recognize that people with disabilities are healthy, they can be healthy, and have the right to be healthy. And as public health practitioners, we really have an opportunity to ensure that that is part of the conversation. So let's look at just really quickly a high-level view of disability in a social context. Obviously, we have to look at social determinants of health of people with disabilities. We know that individuals with disabilities are less likely to be employed, more likely to have low income, less likely to have a college education, more likely to not see a doctor because of cost. And although we have some data around the social determinants of health, this data is really limited and really restricts our full understanding of the roles of social determinants of health and disability. And we also know that we have to look at health disparities and health status among individuals with disabilities. They're more likely to report fair or poor health compared with adults without disabilities, more likely to report 2 or more chronic diseases compared to those without disabilities, and more likely to report 14 or more poor mental health days in the past month when compared with to people without disabilities. So, we experience disparities in the social determinants of health, disparities in health status, and also disparity with regard to health behaviors and risk. We see that compared to those without disabilities, people with disabilities are more likely to be inactive, more likely to smoke, and more likely to be obese. And so we have some significant work to do in public health, knowing what we do know, even though we really don't know as much as we should. And so we talked a little bit earlier about this intersectionality of disability. And this is really the key. This slide and this message is really what I want you to walk away with, leave the session with this concept. We know an increasing amount of disability and health disparities, an increasing amount about health disparities and racial and ethnic status. But what happens when those two intersect, right? And so you have individuals with disabilities who are also part of a racial or ethnic minority. And so in that context, you have a double burden or a double discrimination, as some people have discussed. And so this is a quote out of the HHS Advisory Committee on Minority Health at the federal level. That was, this report was published in 2011. But I really don't think we really understand this yet. I feel like it's just now getting some recognition. And so I'll read this quote to you. Aside from the public health issues that most racial ethnic minorities face, minorities with disabilities experience additional disparities in health, prejudice, discrimination, economic barriers, and difficulties accessing care as a result of this disability. In effect, they face a double burden. And so I think as practitioners in public health space, and as we're discussing health equity in a broader context in much of either our work or in many circles within public health, it's definitely gotten a lot more attention as of late. I think we really have to address this double burden experienced by people with disabilities who are also part of racial and ethnic minorities. And so this is why I feel like it's critical as we're discussing health equity that we have to include disability. And so this is just gives you a couple of the examples of some national studies that have been done that have shown this double burden to be true. There's a study that looks at Black and Latino adults with intellectual and developmental disabilities and found that they were far more likely to be in fair or poor health or fair or poor mental health than white adults with intellectual and developmental disabilities. And then people of color with disabilities are at even higher risk of health disparities compared to other racial or ethnic groups with disabilities. And so when these studies have looked at national data and broken it down even further than we often do looking at health disparity and disability, we see that this intersection of race and disability needs some significant attention. It's something that we haven't been looking at the way that we need to. And so, let me, 1 second. So with that in mind, as we are, again, discussing health equity and so much of what we're doing right now in public health, I found this, we all like the graphics that help explain some of these concepts and the visual that makes this a little bit easier. And I found this out of a Canadian equity consulting firm. And what they've taken is this, the picture that I think many of us have seen, showing the difference between equity and equality. Those first two panels with the individual who uses a wheelchair sitting behind the fence. Everybody has blocks in front of them that are of equal height, but obviously the individuals with a disability, the treatment is equal because they all three have blocks, but the person who uses the wheelchair can't get on the block, right? And then you have on the next panel, you obviously have the equitable treatment where the ramp is added, which is great. It's an accommodation in the environment, and it's really helpful to make that block accessible to that individual. And then, we also see doubling up of the blocks as being another way of doing that so that everybody can see over the fence. And so the treatment is more equitable with some of the changes and barriers removed. But what I loved about this is that if you look at the final panel, you just remove the fence, right? Isn't that the goal of removing those systemic barriers, not just for race, but also for disability? And in this case of individuals with disabilities who are part of racial and ethnic minorities, you've got to do both. And so just showing that the goal, the end game, the overall goal that we're working toward is really getting rid of the fence and removing that barrier. And so, if we talk about disability in the context of race and achieving health equity, obviously much of the same efforts that we go for, that we use to improve health equity for those who are part of racial or ethnic minority groups would apply. Obviously, you can use all of the tools that you already have in your tool chest to address health equity based on race and ethnicity. But when you add disability into the conversation and into the equation, I think sometimes we have to expand our toolkit a little bit and expand our use of things that we have on hand to address the barriers, because the barriers are going to be different for those who have disabilities and are also part of racial or ethnic minorities. And so we're going to just take a couple of minutes to look at some of these barriers. You all may be aware of many of them, but just to make sure that we're all on the same page in terms of the ways that we can begin to remove the fence, so to say, and address some of these barriers. And so if we look at these barriers, and this is not an exhaustive list by any means, nor does it address the needs of everyone, all different types of disabilities or experiences, but these are some that I think in the public health world that is important for us to really pay attention to. We've talked about this lack of environmental access. That's, I think, in many cases, the easy one, and I say easy with quotation marks because it doesn't mean it's easy to do, but I think it's the one that's easier to wrap our head around what that looks like. You know, environmental access, if you put a ramp, if you have grab bars in the restroom, if you make sure that there's accessible parking, those are the things that I think in many ways we might be able to put our head around more easily, or at least be able to identify. But there are others that I think are absolutely just as important, if not more important in some cases, to look at, to make sure that we are addressing the health equity of people with disabilities. If we look at inaccessible communication is a significant barrier for those who have vision loss, those who are deaf or hard of hearing. And I think that those who have disabilities that affect their speech, individuals who have intellectual and developmental disabilities, where communication or understanding or problem solving can be more difficult. We've got to look at the way that we communicate and how that is often inaccessible for many individuals. And I think that one of the other barriers that many people experience is just a lack of training, of understanding among those that are in the provider community, whether that's medical provider community, whether that's public health. Those spheres are pretty large in terms of the points of interaction for individuals with disabilities. But sometimes it's just an issue of just not knowing how to interact, not being comfortable, not understanding some of the issues that may exist. And so really addressing that lack of competency and training is really important. And then I think in many times, we don't think about including or addressing disability and inaccessibility and the need for accommodations in our policies and procedures in many public health spaces. And I think just acknowledging that needs to be addressed in the way that we do business per se. And then ensuring that public health programs and services, many of them are just not accessible or inclusive of people with disabilities. Programs that encourage physical activity, programs that encourage, smoking cessation programs, and all of the things that we do within public health. In many cases, accommodations are not made to make them accessible for people with disabilities. And we saw earlier when we were looking at the data, this is a huge disparity, right? We know that individuals with disabilities need to be more active. They need to stop smoking. They need to address issues of, chronic health conditions. And so this is really important that we recognize that many of those barriers still do exist. And so what do we do about that? That seems like a very daunting task and some pretty significant barriers. So what do we do? And I think in many cases, it's recognizing that they exist and recognizing that there are resources and people out there that can help address them, and then taking little steps at a time to address some of these barriers, because we can't bite off a huge chunk without just baby steps is sometimes the best approach. So if we look at just a couple of quick, again, not exhaustive by any stretch, but just a couple of quick things to think about, things that you can begin to do. Assessing accessibility of a physical space to ensure compliance with the Americans with Disabilities Act. Just the simple process of looking at the space around you, grabbing a checklist off the internet that looks at the Americans with Disabilities Act, and taking a hard look at the space and what environmental barriers exist. That's one of the things that we do in our office with local health departments is use a checklist and go around and and point out areas that can be improved so that the accessibility can be increased in that space. Again, just being aware of what some of those barriers might be, and taking steps to remove them. Ensuring accessible diagnostic equipment is available. Things like accessible exam tables, accessible scales, things that, for somebody like myself who uses a wheelchair, if I go into a doctor's office and there's not a way to weigh me because I can't stand up on a standard scale, then the doctor's not going to know how much medication to prescribe, right? Because they don't have an accurate current weight. And so in that case, that provision of medical care is not, it's not equitable. It's not equal to everybody else that goes into that office, because they don't have enough of the information needed to provide the same level of medical care as they would to somebody who walked into the office. So that's an example of that. And then, looking at accessibility in the community, things like access to transportation and public spaces all have significant effects on individuals' ability to be healthy. And so we talked about effective communication. If accommodations are needed, being able and understanding what accommodations, what to do when an accommodation is requested. If somebody comes and is deaf and uses American Sign Language as their primary means of communication, would you know how to request a sign language interpreter? Would you, know what other aids might be available, or maybe what to do in a situation where you don't have enough time to get a sign language interpreter there? What are some of their low-tech ways that you can help communicate with that person? Making sure that any materials making sure that any written materials that are produced out of your program or office or wherever you may reside are accessible and readable, and are available in alternate formats, maybe large print or an electronic format for somebody who needs that accommodation. And the same with websites and digital materials following some of these accessibility guidelines. Because what is critical, I think, in making sure that that your communication is effective is because if we're sharing a health message and it's not communicated using a method of communication that is accessible because of a disability, then it's not going to be an effective health message. And so we've just got to be thinking about how those messages are communicated for those who have different needs. And then talking about training, I think it's really important, some of the basic just disability awareness training, including respectful interaction and use of person-first language. I think it's important that that's part of cultural competency training and providing culturally appropriate services, ensuring that we all know that language is a significant issue, and so knowing what language to use and not to use to be respectful is really important. Addressing misinformation, stereotypes, implicit bias, and other attitudinal barriers. Again, making sure that you're aware that this stereotypes exist, implicit bias exists, and so the best way to address it is to learn. And then providing training on that effective communication that we just discussed, making sure that staff or other folks that interact with people with disabilities aren't going to inherently understand or know what different accommodations are available, or how to request a sign language interpreter, or how to put materials in alternative formats. And so that's something that needs to be trained. You need to learn it. You need to make sure that that's part of, typical training that's done. And then finally, making sure that policies are reflecting these efforts to make things more equitable, to remove these barriers. And so policies should mandate the equal access and compliance with non-discrimination laws, such as Americans with Disabilities Act, the Affordable Care Act, and policies should include how to request and provide accommodations, and policies including those training requirements. So it all works together and all goes together to remove these barriers and address the needs of individuals with disabilities within public health spaces and programs across the state. And so, the things that I mentioned in those slides, I know I ran through them quickly. It's a lot of information. It's a lot of detail that was left out just for the sake of time. But at the same time, there are a lot of resources that are out there. This is just, I couldn't figure out a way. I didn't know if there was a way on this platform to actually share with you all listings of resources that are on some of these next couple of slides. But I'm happy to put them together in a way that can be emailed. And so we can, so Jerry's saying I can share your screen. So I think right now they're in the PowerPoint presentation, but in terms of letting you do that, I think you may even be able to do a, my mind is blanking on the wording, where just taking a picture of your screen, you might be able to do that. So looking at a couple of these resources that look at full inclusion of individuals with disabilities in public health programs. The NATRO site, there's a site called Commit to Inclusion. There's a toolkit called Public Health is for Everyone that has a lot of information around improving access and inclusion in public health programs for people with disabilities, as well as the CDC Health and Disability and Health Promotion website has a lot of these resources as well. These are just a snippet of some of the general resources around access and inclusion for people with disabilities. As we look at resources specifically at barrier removal, like we talked about at the end, there is information on sites about what the ADA, the Americans with Disabilities Act, says about effective communication. The North Carolina Office on Disability and Health has a publication called Accessible Print Materials that addresses some of the some guidelines for accessibility and readability of materials that you may develop to ensure that they are accessible to the greatest number of people possible. And then we talked a little bit about access in those medical care health, public health settings, local health departments, addressing some of the issues related to what I was discussing, accessible exam tables, accessible scales, and looking at ways to eliminate barriers specifically for individuals with mobility disabilities. There is tons of information on the web about the Americans with Disabilities Act and checklists and things that you can look at for removing some of those barriers. A Google search can find a lot of those materials as well. And so this is, again, just a very, very brief overview of some of the resources that exist. And then I wanted to share, again, this is, I have links on here hoping that I could have shared the actual presentation with you all, but I can get this information to you. I'll give you my email address at the end, and you're welcome to email me, and I'm happy to pass these along to you. These are some of the articles that look specifically at health disparities among individuals with disabilities who are also part of racial and ethnic minorities, looking again at that intersection of disability and race, and making sure, if you all are wanting to take a little bit deeper dive into some of that data and some of that information and issues related to that, these are some really good articles related to that. And I wanted to leave a little bit of time at the end if you all had any questions or comments. If you wanted to put those in the chat box. This is my my contact information. You are welcome to email me for any of these resources or any questions or issues that come up related to addressing health and health disparities among people with disabilities in the state. So I'll just turn it back to Jackie, and I guess just encourage you all, if you have questions or comments, to please put those in the chat, because we've got a couple minutes left before the end of the presentation.
That was awesome, Lauren. Thank you for your time. And yeah, if anyone has any questions, I know that so there was one comment about just mentioning of invisible disabilities. I appreciate that. I've got a little one with a disability, and he wears leg braces, and when he's wearing pants, you can't see it. And we've been in situations, the biggest one's been at the airport, where I've said, can we get some assistance, and getting a look and saying, why do you need that? And do I have to stand here in a public place and tell you that my 5-year-old has leg braces and can't make it to the end of the hallway without some support? So it's my message from that is always, when people ask for help, it's the having to stand up there and say your diagnosis, but just provide support. People don't usually ask for help unless they need it. So I also appreciate the invisible disabilities mention. I think that's just, I always tell him my son, everyone's got something, you never know. But it doesn't look like, Lauren, that we've got anyone else chatting, but I know that you're available and lots of good resources to share.
Yeah, well, just, let me know. I guess we can give people back a little bit of their time. If that's how this works.
Yeah, sounds good.
All right. Well, thank you all so much for joining us this afternoon. Again, if I can do anything, please let me know, and hope you enjoy the rest of the presentations today.